under discussion and should be further studied. Now, about the targets, well, we all know this slide where several targets are of importance. What has been mentioned already is the Bonner trial. What has not been presented here during this symposium, but what I think is a breakthrough this year in the treatment of head and neck cancer, is the results of the EXTREME study, which showed for the first time in 25 years that when you add cetuximab to platinum 5-FU in patients with recurrent metastatic disease, that you have a survival benefit and a very strong improvement of the progression-free survival, as you see here, which is an improvement of 46%, but not at the cost of more toxicity for the patients, and the quality of life of these patients was not worse than in the patients in the control arm. So my conclusion are the following. The multidisciplinary decision-making is essential. A better selection of patient groups for specific therapeutic approaches need to be obtained, and it has been mentioned already by Ezra what is being meant by that. The optimal approach to larynx preservation has still not been decided on, despite the fact that concomitant chemoradiation is used mostly. Targeted therapies are promising both in the locally advanced disease setting and for recurrent metastatic disease. What is missing is that there is no direct comparison of concomitant chemoradiation versus bioradiation. And that means that is for efficacy, but also toxicity and quality of life. And considering the fact that we are more and more worried about the late side effects, I think that such a comparison is extremely important to know what is the value of that approach with bioradiation. Also, a combination of induction chemotherapy followed by a form of local treatment which is less toxic would be very important. And finally, according to what I have heard here in the 2 days, it would be interesting to look for direct comparisons of surgical versus non-surgical approaches in head and neck cancer again. Thank you very much.
Excellent, Jan. It was a beautiful overview. So, questions for Dr. Cohen and Dr. Vermorken? Looks like high-grade toxicity.
late toxicity.
Delayed toxicity. Well, the last but not the least of the final speaker on this panel is Dr. Thomas Hoffman from Dusseldorf, and he's going to speak to us on something yet novel that you haven't heard. Tom?
Before I start with immunotherapy, I would like to pick up your term bioradiation. I very much like it, on the one hand, because it's bringing up a very important topic right now. Bio is everywhere. You have to buy in the supermarket. You want to go for bio products. And it, on the other hand, gives the patient the impression that he's basically going through a therapy which is not very harmful. And this is certainly wrong. So it's very creative, but dangerous, I guess. So let's see. Right, my topic is immunotherapy, and what we have just learned in the recent sessions, that those antibodies, anti-EGFR antibodies, bind to those squamous cell carcinomas of the head and neck, and this is supposed to be a targeted therapy, targeted by means of signaling interference. That means by the interference of signal transduction, you might induce apoptosis, you decrease proliferation, you decrease the infiltration tendency of the tumor. Still, I think we also have to deal here, at least at part, with immunotherapy, not bio, but immunotherapy. And we have shown this previously in some studies where we have taken head and neck squamous cell carcinomas and have checked the results or the effects of anti-EGFR antibodies, have shown ADCC, antibody-directed cell-mediated cytotoxicity. It is NK, cell-mediated, natural killer cell-mediated. This is an old study, but the new one is, which is picked up here in blue, the immune cell infiltration induction by this antibody. And the next panel of a picture will demonstrate that. You have here a three-dimensional tumor spheroid of head and neck squamous cell carcinomas, and if you co-incubate those three-dimensional tumor constructs with immune cells which have been stained or painted with immunofluorescent dye, you will see a certain infiltration of those tumor cells by the immune cells, which are yellow or reddish here. This infiltration is massively induced by the addition of the anti-EGFR antibody, and we have, you can see this in the very right picture, we have identified those immune cells to be either CD3, CD14, or CD16 positive T cells, macrophages, NK cells, and identified MCP1 as a major player for this induction of infiltration. So, coming back to the term immunotherapy, I do think that anti-EGFR antibodies are sort of targeted therapy. They might be also biotherapy, but I would like to stay with the term immunotherapy. And the other side of the coin is not the passive, but the active form of immunotherapy, and this is basically the vaccination. The term vaccine comes from variole vaccine. Varus means a pock or the pox. It's both Greek, and vacca is the cow. It refers to the cowpox, which have been systematically used by Edward Jenner 2 centuries ago. He tried to eliminate the smallpox, and he was successful by this active immunization. 1980, basically the WHO said the pox are gone. They were eliminated. So he was successful by eliminating an infectious disease. We try to go for tumor. So we have to choose different antigens, and we have to go for the tumor antigens as a vaccine in order to induce a T-cell response. And this is pretty tough. That's how it should look like. We have here the tumor cell. On the surface, we do have the antigens. And those antigens should provoke the T cells in order that those guys try to eliminate the tumor cell. This is the ideal perspective. In reality, this simply does not work. Either the tumor cell antigens are too weak, the T cells are tolerized or impaired by the tumor cells which are secreting factors which suppress the T cell function. So we have to have an amplifier, something in between which enhances this T cell response, and the most potent antigen presenting cell is certainly the dendritic cell. And with this tool we might be able to increase or enhance this immune response. In order to do so, we need to pulse or load these dendritic cells with antigens, with tumor antigens. And you just said it, HPV might be one target. It's a very nice target in oropharyngeal cancer because it's highly present, in 60% approximately. And you might go for those tumor antigens. HPV16, we have done so. We have shown an in vitro response so far. You could also go for P53. This is a overexpressed protein due to a P53 mutation, which is also around 60% present in all head and neck squamous cell carcinomas. Or you go for EGFR. That sounds very easy and good, but the problem is that you chase single antigens. And you will face, this came up during one of those sessions as well, you will most likely face, comparably to chemo resistance, you will find immunoresistance in terms of immunoselection. You give the vaccine, it might be successful, but then there will be a grow up of other tumor clones which are simply negative for P53 or HPV16 expression. Therefore, you cannot simply go for just one antigen, you have to go for multiple antigens. You maybe also have to single tailor the vaccine for special patients. Or you go for a very broad spectrum or broad antigen panel in terms of proteins or lysates or apoptotic tumor bodies. You also could go for RNA and DNA. That means this column, protein, RNA, DNA, is simply broader. You will chase here antigens which you don't know, but you have a very broad spectrum of immune responses. We have done some clinical pilot studies. I have to really tell you, it's not a phase 1, 2, or 3, which we have heard a lot of those phase 3 trials, very impressive data. But we are not here. We were just at the stage of pilot studies, very preliminary data, even in patients, but pilot studies. We have started with dendritic cells plus apoptotic tumor bodies, and it was technically feasible. It was very well tolerated. The toxicity was extremely low. We injected this vaccine, dendritic cells plus apoptotic head and neck squamous cell carcinomas, into the lymph nodes, which were in the groin. That was all fine, but it was technically very difficult in terms of obtaining enough tumor material which was sterile and which you could propagate in a GMP facility. So this is certainly not an approach which is feasible. Particularly, it's too expensive. So we went for another approach, dendritic cells plus p53 peptides. This trial is currently running in collaboration with the University of Pittsburgh. The same is true with dendritic cells plus DNA, the broad spectrum vaccine. Still open, this trial. But we also have to recognize other trials which have been just published a few years ago by another group in Heidelberg, by Harold Mende. Very nice trial. They used head and neck squamous cell carcinoma. They created a cell line and transfected this cell line with a Newcastle disease virus as a danger signal in order to provoke the T cells or the immune system. It was a successful trial. Very nice feasibility, and toxicity was neglectable. Certainly, as a pilot trial, you cannot make any comments, or you can just suggest something, but you cannot really say about efficacy of the vaccine. This has to be done in larger ones, in larger trials, and this is very difficult to finance. So this is my statement for immunotherapy for head and neck cancer. The use of anti-EGFR antibodies is approved targeted immunotherapy. Whereas the vaccinations, this is in the stage of the pilot studies, not approved. We have to work, we have to bring in a lot of effort in order to get into a situation where the anti-EGFR antibodies are right now. And the goal will be not to use it as a single agent, certainly not. You are not able to get rid of the big tumor bulk, but you might be able to fight minimal residual disease when you combine it with the standard treatment options like surgery, radio, and radiochemotherapy. And the final goal would be to induce a tumor-specific immune response, a memory, which will allow you to bring down the rate of recurrences and to enhance prognosis. Thank you.
Thank you, Tom. Any question, comment?
Well, can I have a question?
Okay.
I just wonder, in those tumors that have T-cell infiltration spontaneously, are they doing better?
There have been several studies by Theresa Whiteside, but also by Barbara Wollenberg and Lübeck. It is indeed the case that the more TILs, tumor-infiltrating lymphocytes, you have in the tumor, the prognosis is better for the patient. But on the other hand, those tumor-infiltrating lymphocytes are impaired by the tumor. That means when you want to try to extract those guys and try to use them for adaptive therapy, for instance, you will be very surprised because they are simply impaired in function. They don't work because the tumor is pretty aggressive. It's very immune suppressive in the head and neck cancer situation. Therefore, it's certainly not good for chasing those tumor-infiltrating lymphocytes in order to use them for therapy. But the prognosis is better.
Yeah.
Question?
Thank you very much for your very nice presentation. One question which is keeping all of us very awake in these years is the question of the tumor stem cells. We see a lot of cells with antigens and which can be damaged by a lot of targets, but at least the hypothetic stem cells, they go down and they wait until everything is over and they come back. And my question is, what is to the panelists your belief in this theory of the tumor stem cells, and have you any approach to detect them?
I have to bring to memory the talk of Barbara Wollenberg. She gave a very nice presentation in the perspective session last day, and she was basically talking about the stem cell business, and she showed CD44 positive cells to be potential tumor stem cells.